And I want to just start with a little bit of overview of what we'll talk about. We'll spend a little bit of time talking about basic principles of endovascular thrombectomy for dialysis. So kind of just the basic ins and outs of how to do a declot. And again, this is where I like to do this live because we really can talk about how everybody does it, at their own place. This is a lot like cooking. The same thing, especially a declot, the same thing everybody does a little bit differently. So we always learn from each other in that process. We're going to go, briefly review some of the updated QDOKI guidelines with the most recent guidelines that just came out. We'll talk about some future directions, and then we'll go over some dialysis and then some other, venous cases that I use in the report. So, but first, the best declot is no declot. Again, we really want to strive to prevent our patients from coming to us with clotted access. And again, declots at best are technically easy. But they just require a lot of time and effort. And unfortunately, at worst, you're left searching for why you didn't just do mammography or something like that. They can be a pain and really difficult. And then, again, like we talked about, prevention is really important. So, when to image, we really want to image dialysis access shunts under two conditions. One being the presence of a clinical abnormality that, impacts the quality or duration of dialysis. And the second thing is to prevent acute thrombosis. So we really want to catch these ahead of time. And so we're looking for these clinical abnormalities. And in general, we don't treat, images. We treat patients that have clinical problems. So the things that we often will get referred or have our patients present with are high venous pressures, cannulation difficulty, prolonged bleeding, upper extremity, swelling or edema, inadequate flow, and then some sort of abnormal lab parameter that suggests inadequate dialysis. So again, a lot of declots, sometimes is out of our hands because a lot of it starts at the dialysis center. So, if you have good nephrologists and you have good, access center or dialysis center staff, you won't be seeing as many declots as, other places, for example. And so, what we really need to train ourselves and others on is, really monitoring for decreased thrill or hyperpulsatility, swelling, collateral veins, flat arterialized veins. So, signs that there's low flow in the circuit. And, specific numbers that we want to kind of think of is, for grafts, we want higher flows or when they get less than 600 or between 350 and 500 for fistulas. Those are going to warrant imaging to rule out an underlying stenosis. And then also, if you can, we always like to encourage getting duplex ultrasound to assess for abnormalities. And this is just an example of a patient, that we probably frequently see with the, asymmetric arm swelling and some collateral veins that suggest that there's a central venous stenosis. Again, when you want to figure out what is going to be causing a problem with an access. I had an attending once that told me, what made Mario Lemieux so great, and specifically as a hockey player, what made him so great was that, he could predict where the puck was before, that the person passed it to him. And so, all of interventional procedures, this is very applicable in HD access because really knowing the type of access the patient has will really help you predict where the problem is going to be. So you kind of know where the puck is going, I guess, for example, if you know what type of access they have. So, a forearm fistula versus an upper arm fistula versus a graft will all vary with the type of stenoses that they present with. So, and when we're talking about forearm fistulas, we're talking about, your Brescia-Shimino fistulas, and these will present most commonly with issues at the juxta-anastomotic area. So these are the fistulas that we're most frequently puncturing retrograde as opposed to antegrade, because we know the problem will probably be near the anastomosis. When we talk about upper arm fistulas, these are going to be more commonly downstream stenoses from the cannulation site. So when we're talking about brachiocephalic fistulas, we're going to be, kind of honed in on the terminal cephalic. Brachiobacillic transposed fistulas are more likely to stenose in the venous outflow near the axillary groove. So again, for both of these types of fistulas, more distal or downstream to where that the access is cannulated. And then for AV grafts, these are probably the most reliable where they're going to present with issues, and that's going to be at the venous. And then in addition, it's going to be less commonly in the outflow vein and least commonly within the graft itself. So again, venous anastomosis for an AV graft. And as I sort of alluded to, doing a declot, every single place probably will do it just a little bit differently. And it's not to say that one way is right and one way is wrong. It's just that everyone will probably get, to the same point. But the things that will probably differ is, the tools that are used, the medications that are employed. Some people give TPA. Some people only give, like 3,000 heparin. Some people give up to 10,000. So and the devices that they use. So the things that will really vary is the cost of the procedure. You can do a declot with literally, $5. From you're just using balloons, no sheaths, or it could be 50,000. If you're there are centers that will lyse these patients and admit them to the ICU. So you can imagine the cost from that is can be astronomical. So again, just like all of interventional, you really have to find a way that works for you. But that's also cost and time effective. So it's that fine balance of doing things the right way, but also making sure that it's cost effective and doesn't take too long. So with that, this is just my approach to dialysis declot. I think it's a fairly commonly used method, but again, it's not to say that this is the only way and this is the right way, but this is the way that worked for me, and it works pretty fast and it's pretty positive. Basic principle with all of declotting, is that you have to remove the thrombus, and then you have to, secondly, fix what caused the to shut down to begin with. If there's no problem, then that's a very ominous sign. That means there's something intrinsically wrong with the access, or the patient has, like poor cardiac output or something like that. So remove that thrombus and then fix the downstream stenosis in this situation. So before we go into how we do that, we always want to kind of go over the contraindication. So absolute contraindication will be a graft infection. So if you suspect the patient have a clotted access, then you are not going to do a declot, and that's going to be a surgical consultation if you're not a surgeon. Relative contraindications, and I'll tell you, we probably violate this more often than we want to, but these are things to keep in mind. So a patient that's fluid overloaded or hyperkalemic, those are the patients, again, you want to maybe consider getting temporary dialysis before you declot. A non-maturing fistula that's never been accessed, and then a thrombose access that's been thrombosed for greater than a month. Again, that's going to be more relevant probably for a fistula. Grafts, you can tend to be more aggressive with declotting longer out. So just basic principles of grafts versus fistulas. AV grafts are going to be very simple to declot most often, but they come with the caveat that they're more prone to rethrombosis. So while they are going to be easy to do, you're going to be doing it more often. So that's kind of the drawback of them. What makes them so easy is that they typically have a uniform configuration. They have a very small thrombus burden, it's like roughly 3 to 4 milliliters of clot. And then, as we mentioned, the stenosis is very predictable, usually at the venous anastomosis, such that literature suggests that we should be primarily stenting those when they come with issues. And then fistulas, on the other hand, are going to be more complicated, but they clot less frequently. So they're going to be better accesses, again, in general, that we favor. But with that said, when they do clot, it's going to be more painful to get them open. And a lot of that is because they have greater anatomical variation. They have a longer and larger thrombus burden. Often that's because they have aneurysms. And they have less predictable areas of occlusion or stenosis. Again, we showed some of those graphs of where they tend to stenose. And, like we mentioned, fistulas are less often worked on. They have about 3 to 7 times less access interventions. As far as the technique for declotting goes, like I mentioned, the procedure honestly is not very difficult from a technique standpoint. It's just the time and energy and effort that you need to spend to get things open. And really, the only things that I think are actually difficult is the management of the complications per se. So again, this is my technique, and this is how I deal with it. Again, we can probably, when we get to the questions part of this, we can kind of discuss to see how other people are doing this. But typically, I always give antibiotics to patients, and and 5,000 of heparin as well. Again, this is to prevent potentially septic emboli and also to treat, again, heparin to prevent reclotting and potential bronchospasm with PE. And then I typically get 2 accesses in opposite directions. And these 2 accesses, we label this as the venous limb, which is one here. That's like what's called the outflow sheath. And then the second one directed towards the artery or the arterial limb. We call that the inflow sheath. And then we start by after we get those, or after I get both of those accesses, go centrally, and we want to verify that the central veins are patent, and you want to delineate the extent of thrombus as well. So we want to check that the central veins are open, and then we want to kind of puff contrast until we figure out where the axis is actually starting to clot. And if there's any major underlying culprit lesion, you want to address that up front. You could imagine if you have an occlusion or a severe stenosis centrally. If you didn't do anything and you just declotted it, it's going to clot immediately or on the table, or it might never even open at all because the stenosis or occlusion is so severe that it will prevent you from ever getting high flow. So, and then you want to, once you've kind of verified central venous patency, you want to clear as much thrombus as possible before turning your attention to the arterial limb. And I can't stress this part enough. I think this is the part that most people try to do fast. And this is the part that will probably lead to reclotting on the table and into those 2 to 3 hour declots, because people want to try to skip this step. And this is really like the equivalent of shoveling this. Like if you imagine snow on a driveway, you want to shovel all that snow off the driveway before you take the car. Open the garage and take the car out. And so if you kind of are sloppy about that part, when the car comes out, it's gonna slip or crash or whatever. And there's a variety of methods to do this, and this is really what will be the kind of bulk of this talk. So, just some pictures. Again, this is a hero graph, but this is what I do. I usually do a pullback venogram, and then the yellow arrow shows where sort of the axis starts to clot, and the rest of it centrally is patent. Another example you can see here on the central venogram, there's a subclavian stenosis there that we first angioplasty and fix before we start the declot, again, to make sure that when we do get high flow, that it's not gonna the central veins will accommodate that flow and not rethrombose. So just some general points, and this is more for the kind of lesser experienced folks on the call or trainees. What's very important is you really don't want to inject contrast within the thrombus. This is very relevant the closer you get to the artery. So you're never doing power injections until until everything's open. You're never really injecting into clot, forcefully. You can always kind of puff, especially if you're centrally in the veins. But as you get closer to the artery, you never want to do this. And the main reason is then you're going to turn this into a from a 1 to 2 hour procedure into, potentially a 4 or 5 hour procedure and potentially a surgical consult for a cold limb. So, I think the second point is that, there's a lot of mechanical methods for clearing thrombus, and you can be as simple as just ballooning everything and sweeping it with a balloon or a Fogarty. You can use a Teratola, you can use a cleaner, you can use an angiojet, you can use thromboaspiration. There's a lot of different devices that you can use. But then in addition to mechanical, you also have these pharmaceutical methods. So you can inject, a TPA or equivalent. And again, there's different ways that people do this. You do it through an infusion catheter. You can do it directly through the thrombectomy device, or or the way some of my partners do it is during a pullback of the catheter. And again, this is often done. This can be done prior to the procedure to loosen the thrombus. So I know some people in practice, again, depends on your practice, but in holding, they'll go out in the pre-procedure area, and they'll go in and take a little micropuncture needle or lidocaine needle and inject the TPA before the patient even comes back. So and in doing this talk a few times, I've encountered folks who do this and say it really works. So if you have that mechanism, that's also, obviously TPA works better the longer it dwells. So that's another kind of trick that you can kind of consider. So getting to the arterial limb axis, once you have, again, kind of shoveled the snow off the driveway, the venous end is cleared, then you can go into the arterial limb and you can open it to restore patency. And, the important thing is that the thrombus at the arterial anastomosis, forms this firm and rubbery plug. We call it the arterial plug, but it's, it's this plug that's rich in fibrin, platelets, and blood, red blood cells. So it's kind of this, it's a different nature of this clot. It kind of has this almost like a subacute thrombus kind of composition to it. And so it's important to essentially position your catheter beyond that plug and release it. I use a Fogarty balloon. You can use, other types of balloons, but, at the end of the day, you just want to be able to pull that plug and reopen that anastomosis, and that's what provides the flow to the axis. So in a successful declot, if you've cleared the venous limb and then you pull this plug and kind of, essentially opening the garage, that in itself is pretty much the end of the declot for the most part if you're successful. So this is, again, this is that same HERO access. You can see that this catheter, that is the yellow arrow, is actually injecting from the artery, and that wire outline is actually showing where the access is. And so this is right before we pull the plug. I usually do an arterial run just to show the artery. And then as soon as you pull the plug, this is an ideal, this is what you ideally want to see after you pull the plug, is that the access is patent. And then again, usually there's some downstream stenosis or something that you need to fix here with balloon or stent. And then again, this is with HERO, declots tend to be more straightforward, have less issues that you need to fix, but this is what you want to see, a patent access. So again, once the flow is restored, contrast injections are performed throughout the shunt to fix the underlying stenosis. You could either do plain or drug-eluting angioplasty with or without stent placement. So you have a bunch of different options available to you. And again, this is going to be, some of this is a little bit controversial with the DEB, but in addition to using stents, but those are your options available to you. And then, residual clot or stenosis, again, for me, and what literature shows is that in grafts, you want to get them looking as clean as humanly possible because they're more likely to thrombose with any type of, residual clot. Whereas a fistula, if you're getting good flow, high flows, you're going to have more likely to autolyse some of that clot. So I don't, get OCD or meticulous about clearing a lot of that stuff. With that said, pseudoaneurysms in fistulas can harbor a lot of thrombus. So I really do try my best to debulk them as much as possible. Again, with the idea that you want to debulk as much as you can, but getting good flow or getting patent flow in a fistula is really the objective endpoint. So I've spent a lot talking about how to do a declot, but I haven't really talked about the cleaner device, specifically. And the reason is, it's one of many devices available to you. It's my personal go-to when I do declots. And, I think the Argon folks on this call will probably admit this to you as well, but, it's marketed as a thrombectomy DVT device. But for me, I really feel that it's the optimal and sometimes even forgotten device in dialysis. And I have a bunch of, reasons that I list for that. And, I think there's a good number of reasons. One, it's really simple to use. Like we're not going to spend any time in this talk talking about how to actually use the cleaner device because I think it's insulting to most people's intelligence because it's that easy. You just take it out. There's essentially 2 buttons, and it's very, very, very intuitive. It's very fast. Again, the main objective for most people doing declots is to just do it fast and to do it efficiently. And so this is a device that really permits to you to do a declot very fast. Again, there's no assembly or anything like that. You just put it in and you can go. It's super safe. It doesn't get caught in stents. I think there's other devices that kind of have a reputation for having issues with, especially in like newly placed stents. And so with the cleaner, it really doesn't have that issue. Again, it's highly effective. I find that, it's low profile, so it either goes through a 6 or 7 sheath, depending on the device you want to use. And it's really great for both grafts and fistulas. So, I use it for grafts because as we mentioned, we don't want to tolerate any clot or residual clot within grafts. So I tend to use it for that reason. And then for fistulas, I tend to use it more because of the pseudoaneurysms, and really, again, to effectively debulk those pseudoaneurysms with that sinusoidal wave that it has. It really is effective for, getting wall adherent thrombus. And then it's super cost effective. My personal philosophy on this is that, if you don't believe in thrombectomy devices, then nothing will ever be cost effective, right? Like if you're a balloon person, or you think that you should just use balloons for every declot, then nothing will be cost effective as far as products go. But if you do think that thrombectomy devices have a worth or a place in your practice, then this is a very competitively priced device. And again, we talked about how we want to use things that are cost effective, but also
Oz?
Yeah.
We do have a question, and the question states, the risk of showering pulmonary emboli with cleaner. And as you know, we do have the indication if it's utilized for DVTs, it is recommended that an IVC filter be placed. But what about in the AV graft and fistula arena?
Yeah, so that's a great question. So I think that PE is an inevitable outcome of any declot procedure that's done, regardless of the thrombectomy device or method that you or declot method that you use. So that's a great question, and it gets to the core of the question. I think is what do we do about the PEs that we cause? So if you're using balloons, you're probably lacing the clot with TPA usually. And so there is literature that shows that from the PE that we cause from doing repeated declots, it does not lead to chronic pulmonary hypertension, which is interesting in itself. But then the next question is why? And I think the reason why is because you're macerating the thrombus, you're lacing with TPA, and so probably because you're kind of whipping it up and also kind of impregnating it with TPA, it probably just lyses on its own, and it probably resolves. So I haven't seen that issue with any type of declotting method, and that includes using cleaner. I think the risks with cleaner, and we'll probably go into this or talk about this when we talk about other types of venous cases where there's a much larger thrombus burden, is that, and specifically the type of thrombus when you're talking about like subacute or chronic thrombus, is that you can potentially send bigger chunks of clot. Now with declots, I don't think that's relevant because, again, grafts, small thrombus burden, and the vessels are just smaller. So you're getting a much more effective maceration. The clot is acute. If it wasn't acute, you wouldn't be even doing the declot to begin with. So it's a very long-winded answer, but I hope that makes sense to the person. Mary, I can't see my...
I don't have a follow-up question, so I'm hoping that that sufficed. I think it was a great answer. There is another question in the chat box that says, dear colleagues, what is your favorite bibliography to study this topic? Maybe articles or a specific book. Oz, do you have a favorite?
Yeah, so that's a really good question. So Dr. Turmel, Dr. Turmel, I'm forgetting his last name, but he's a very famous French interventionalist who's published a lot on dialysis access. And he has a book specifically on dialysis access and intervention. It's a little bit older, but it's a really nice book because it's specifically about dialysis access. And as far as articles go, I think, JVIR probably has a pretty, extensive amount of literature on this. Specifically, there's a lot of literature from, Penn, and Dr. Teratola has published a lot on this. And then the other thing that I would suggest to mention, we'll go into this, is Yudoki guidelines for vascular access. multidisciplinary, kind of working group that kind of publishes guidelines on treating dialysis patients. And so I think between those three resources, that's a lot of information and a lot of really high quality information that you can get. I'm not sure if others have any suggestions or thoughts.
Thank you. I did find that physician's name online, and I will type it into the chat box. And I think those are the only questions currently.
Yeah, I said Termel Rodriguez, and I wasn't sure about Rodriguez, but yeah, thanks, Pete, for verifying. Okay, great. If there are no other questions, and please feel free to interrupt me with questions. I think it breaks up the lecture nicely. So I'll keep going. These slides, actually, I'm going to skip through. I had these hidden before, so I think that'll just to save us a little bit of time. All right. But if anyone has questions about accessory veins or immature fistula salvage, I'm happy to talk about that too. But just a recap of what we talked about. Cleaner and other thrombectomy devices can be useful to clear as much thrombus as possible on the venous and grafts, and that really decreases the resistance to flow. So again, it's that concept of shoveling the snow, getting the driveway clear as possible. Again, I'm a believer in thrombectomy devices for that, accomplishing that. And then I think if you're going to use it, or if you're going to try to limit your use of thrombectomy devices, I think it's most helpful for aneurysms of fistulas, as well as when you have intragraft degenerative changes, and like what I would consider to be more chronic or subacute thrombus, which you do encounter from time to time. And then most importantly for everybody is to really find a method that suits you and aim to perfect that method. Don't kind of use multiple different things for this is not just for declots, but for every procedure, just to really try to find one method that's fast and cost effective. I'm going to transition this into discussing a little bit about the KDOQI guidelines. Oh, I saw that there's another question here. Let's take a look. Oh, great. Thanks, Pete. And the KDOQI guidelines, it's a quality initiative. Again, it's a like a multidisciplinary group that basically said, how are we going to improve outcomes for our dialysis patients? And they have specifically a subset of KDOQI is on vascular access. And so they, again, that's on interventions for getting patients access to get HD or PD. And the last update was a while ago. It was 2006. And then since then, they had a few clinical updates that we'll go over. And then just very recently, they published their the latest update to the vascular access subsection, and that was published in March of 2020. So when I first made this lecture, they were not out yet, but since then they've been out, and so I've updated this talk to kind of include some of that stuff. So, I'll just very briefly go over kind of the timeline from 2006 to where we are today. So again, I don't think you can meet anyone that does dialysis access without them knowing about this concept of fistula first. And that's what happened in 2006. There was a large prevalence of grafts and catheters, and so KDOQI really harped on this concept of fistula first, to really aim to get everybody a fistula if they can, if possible, with the concept that you want to start peripheral and work your way up the arm if possible. And then, secondarily would be a synthetic or biologic graft, and then tunneled catheters were kind of the least desirable or least preferable. And the main reason was, there's a very high risk of infection with catheters, about 8 times higher than with fistulas, and then it's about 4 times higher with grafts. And since 2006, they published a clinical update 6 years later. And the focus was really, again, to try to get patients away from catheters and more towards, shunts, whether that was fistulas or grafts. And again, the preference was for fistulas. But they did, you know, kind of talk about the concept of having hero grafts considered as an alternative. And the rationale being that there's a lower rate of infection, improved adequacy of dialysis, and then it was also comparable in terms of performance with regular grafts with respect to patency intervention. I'll mention that my personal experience, and I'm sure this is probably true for most people, is that you know, hero grafts tend to clot much more frequently than other types of accesses, you know, specifically grafts and fistulas. And the main reason I think is because any period of hypotension can induce thrombosis. You know, up to a 90 centimeter device that's just a long plastic tube, you know, so there's really a high chance that any, you know, disturbance in flow can thrombose. And again, this is ideally for patients who have a good ejection fraction, ideally much higher than 20%, and a high blood pressure higher than 100. Saw a few questions or, oh, no worries. Okay, great. All right, so then in 2016, 4 years later, there was another clinical update, and here there was an emphasis on needle selection. So this is something that we probably, again, as interventionists, not that actively involved in or that we think about, but important to just mention that, you know, needle selection can actually play a role in preventing access thrombosis. And the concept is that, you know, infiltration, hematoma, or repeated needle cannulations essentially result in vessel trauma, and that results in access thrombosis. And again, that vessel injury can result in endothelial damage, which causes leukocyte adhesion and neointimal hyperplasia, and that leads to a venous stenosis. So again, just the concept that even the needle that you're using at dialysis can be prone to causing thrombosis. So they have these general needle recommendations to start with the access needle, like a 17 gauge needle, and use metal, stainless steel, or plastic dialysis needles. And then the needle should have a back eye, and the ideal length should be about 1 centimeter. And again, the concept being that for newer accesses, the smaller the needle, the greater resistance to flow and a lower blood flow rate. But you want to start smaller, and then you kind of increase the needle diameter as the patient tolerates. And then finally, you know, most recently, which was just published a few months ago, was the 2019 vascular access guidelines. And I encourage, before I even, you know, going over this, is that everybody that's treating dialysis patients needs to read these guidelines and really understand what's different and what's changed. But I'm going to go over, you know, kind of a very brief cursory review of some of the major kind of position changes or statements that were made. So, you know, if you read through this, what you come away with is that this working group really recognized that between 2006 and 2019, there was a really, you know, there was a lot of literature and data that's been kind of published in that time period. And so they've started to put a lot more weight on their recommendations with a focus on evidence. And so if there wasn't a lot of evidence on those, on prior recommendations, they tended to soften up on that. And so a few new concepts that they talked about was this idea of a life plan, and we'll talk about that. Choices for access and catheter placement. They specifically, you know, kind of listed those choices out again, and then the management of specific complications. And again, a very big theme from this updated guidelines is that, you know, again, this Fistula First initiative, which again, everybody who treats these patients, you know, has burned into their head, is they're really moving away from that, and they're really now emphasizing a patient-centric approach. And I think there's a point in there where they talk about the right access for the right patient at the right time. And so instead of just going Fistula First, now they really are stressing that depending on, you know, the age and comorbidities and the needs of the patient, you really need to all be taken into account when planning access. So for some patients, that actually might mean a catheter. For some people, that might mean a graft. And again, still for most patients, probably means a fistula. And so it'll be interesting to see what effect that has moving forward. But it is a big theme of the new guidelines. And with that is this concept of a life plan. Plan being an acronym for patient, life plan, and access needs. And again, you probably can't, you know, obviously don't have the time to discuss all of this, but there's a big emphasis on that. And then, like I said, the guideline recommendations have changed based on the strength of evidence. And so they've softened or strengthened these recommendations based on the degree of evidence available. So it's no longer just, based on consensus opinion as much. And, one interesting thing that they kind of mentioned is the order of preference for catheters, which is, internal jugular first, external jugular second, and then interestingly femoral, and then subclavian, and then lumbar. So again, for a lot of people, that's a little bit of a change from what we're used to seeing with most. Sorry about that. There's no specific recommendations on drug-eluting, drug-coated balloons or endovascular AV fistulas. Again, citing, this was again done mostly in 2019, so there's limited data to this point on that. And then again, also very interesting enough, they established some future research directions. And again, this is really nice because it's important that some new research directions have been established for people like myself who are interested in research to kind of see what holds for this field. So let me just see 1 second. All right, so I just want to, again, wrap this up by saying, what is the relevance of this? It's important for us as interventionists to stay up to date on these national guidelines and literature. And, again, we want to provide comprehensive care in an exceedingly competitive market. So we need to really transition away from being proceduralist. Again, we all must really read these guidelines. And just a little bit on E&M coding. Prior, there was essentially these two codes, and now 36904 is describes a declot procedure of a dialysis circuit. And in 2017, this is essentially bundled to include all punctures of the circuit and all catheterizations performed. And so, if you look at the work RVUs for a declot, it's about 7.5, which is roughly equivalent to a port, I believe, which we all know a port can probably be done in a very fraction of a time compared to declot. And this is just some data or some of my work that I published, again, looking at, how we're having a lot more providers in this space for doing declots and fistulograms. But what's interesting that you need to pay attention to is that, the number of fistulograms are just going up in general. So while there are multiple other specialties doing this, the number of procedures are still going up. So again, this is a pie chart looking at, how much in 2005 were being done by surgeons and radiologists and nephrologists. And now the pie looks like it's, more evenly split. And the same thing is for, by setting. We're also seeing this being done in the OBL or outpatient setting more often. So again, this is just reflecting real world changes. And, what to make of this is that the pie is growing. Most specialties involved appear to be converging towards an equal market share. And again, it's incumbent on all of those who are involved taking care of these patients. We really need to become proficient with all maintenance procedures. And again, as the reimbursement is getting tighter and tighter, we need to, focus on doing these fast and being cost effective as well. So again, that will really emphasize, as we move forward with, increasing cuts. And then this is just some even new data that came out with the 2019 proposed rates. And you can see that, we're going to, so that there are going to be reimbursement cuts with stenting that's done in the outpatient setting. So we'll probably potentially start seeing less stenting in the outpatient role. All right, I spent a little bit more time than I wanted to kind of going over some of that stuff. So I want to finish with some cases. I know we have about 10 minutes left. I just want to show everybody just again, a basic declot. This is a central venogram. And this is an example of me doing kind of a pullback venogram. So we just kind of inject, and as suspected, the clot seems to start right at the edge of that stent. So there's probably like an edge stenosis there. And so what I typically do, again, there's nothing there to angioplasty. I want to do a thrombectomy. So I get, so for this case, we did use the cleaner. We get the cleaner device again, distal to the clot, and then we kind of pull it back. And then again, showing how I like this case because it has a couple different examples of why I like cleaner. One being that it's nice and easy to use within stents. And again, kind of going through the stent, and then to do an angioplasty there as well, just to fix the underlying stenosis. And this was, post declot. You can kind of see that the flow is kind of ratty, and there's some additional clot there, and it's specifically within the fistula. So again, pulled the plug again and did some additional cleaner, which I don't unfortunately have a picture of, but you can see how the aneurysms are now nice and clear. And again, an example of using it through stents, but also for aneurysms as well. It's pretty helpful. So, and then we'll go back and see that there's some additional stenoses that we want to kind of fix that we didn't see, and additional angioplasty and get it looking better. All right, another case, here's a thigh graft. Again, we know that the venous anastomosis is probably going to be the problem, so we go up there and angioplasty that, and then use the cleaner device to to clear the venous limb, and then now go to the arterial limb and pull the plug. There's the Fogarty there, and then again, this is post pulling the plug. You can see that the graft is now open, and there's a little bit of stenosis at the venous anastomosis or residual. So we go back in there and re-angioplasty and go up to about an 8 millimeter on this, and it looks better. And then here's a recent case with another graft. Again, you can see there's a central stenosis there. So we first angioplasty that looks better. And then here's the pullback venogram. You can see all this clot here within the stent. And then the arterial injection, again, post-declot. So in this one, we didn't use thrombectomy or cleaner primarily. But once we pull the plug, you can see now that there's residual clot within those two small graft aneurysms. And this is just a video of us doing the cleaner in there. So this is just showing that you can do it even with the wire beside it. And that's post cleaner. Looks nice and nice and open there. And next case, this is again another. I like showing this because I'm not sure if anyone knows what they're seeing here. But in the interest of time, I'm not going to poll the audience. This is actually. I've never seen this before, but this is, and this patient's been coming to us for about 3 years now, I think. This is a femoral hero graft. So this is a really interesting placement. It wasn't placed by, I'm not really sure the reasoning why, but again, this is just showing that you could use cleaner for this, and we use the cleaner all the way up through that. Angioplasty pulled a plug, and you can see that this hero graft is all the way to the right atrium. So this is probably the world's longest hero in existence, because it's probably not cut, as my guess. And then here's just the post showing the whole thing open. All right, I just want to wrap up with some non-dialysis cases here real quick. And again, I apologize because I used a little bit too much time, and I really like showing this case because it really gets the audience involved. But this is a 42-year-old male with right lower extremity swelling, had a Denali filter placed 3 years prior, and had a right iliac vein stent placed at that time. And he came back with what looked like, thrombus in the stent. And this was his venogram, for the retrieval and thrombectomy. So what we did was we had to recanalize the stent and angioplasty below the filter. And before we took out this filter, we placed a suprarenal filter. And you'll see why that was important. I saw that there might be a question, so I'm just going to look. Oh, so the question is, have you used cleaner in conjunction with other devices? So for dialysis, I have not really. More from a cost perspective standpoint, I haven't really felt the need to ever have used another device. Plus, I also think it'd be cost prohibitive. But I think for non-dialysis cases, it's very it's very helpful. And I think some of these examples that I'm going to show will be good for that. So this patient, again, we were able to reestablish a channel below that filter, and we placed the suprarenal filter, and we took out this filter. And post retrieval of the infrarenal filter, we were left with this. We saw this, in our suprarenal filter. Now we saw this essentially this boulder, And this is a young patient, otherwise very healthy, 42-year-old, active, working, and now has this kind of giant clot there. So, and repeat venogram, again, confirming that it was a real finding and not just some artifact. And again, this is, I would be asking a poll question here, but I'm going to just skip just in the interest of time. And again, I apologize. We chose to try to do a trial of anticoagulation and bring the patient back in 3 months. And sorry, I just saw a quick question. When you use the cleaner for HERO, do you use it in both the graft and the catheter portion? The answer is yes. I use it from essentially you could do it from the right atrium all the way back to where you accessed it. So yes, you can use it in both parts of the HERO. And then, so sorry, back to this case, we tried a trial of anticoagulation and bring the patient back in 3 months. And I think for a lot of people, they might say, why would you ever do that? I actually have cases that can show that actually does work. So it's a reasonable strategy. But in this situation, unfortunately, it was not. And, this is what it looked like. And so the question is, what would you do? And what we decided to do was, let's try to do some penumbra. And this was before Cat 12. And so, we tried that and we were left with this. So basically no change. And the question is, what would you do? So then I think, most people say, okay, well, let's try cleaner and or not most people, but that was what we decided to do. And this is kind of, this is a little bit sphincter tightening in the sense that you don't want to get this, device caught in the filter. So I'm not sure even in retrospect if I would do this again, but you just want to be very careful if you're doing something like this. But actually, to our surprise, it didn't do anything. It didn't touch it at all. So, for all intents and purposes, cleaner wasn't, the right thing for this. So, and this is a real patient. This is a young guy, and the stakes are pretty real here. I didn't want to just leave this. Again, if we had more time to discuss, we could talk about how we could potentially just leave this for the rest of his life. But he's young. I would worry about his renals potentially getting thrombosed off, or his whole cava getting rethrombosed. And, and so I knew we had to do something, and, or I felt that we needed to do something. And so, again, I wasn't shy about, asking others. And this was that was the third time that we treated him. So I also didn't want him to kind of lose faith in me. So I told him that this is how complex this was and that we would talk to other people. In talking to some of my senior partners, other people who I trust, they said, why don't you just go for it? Why don't you try to get the whole thing out? Just put a big sheath in and just try to get it out. But I said, okay, well, that's fine. But if this thing goes to the heart, he could maybe die. So, so we got CT surgery. I consulted them. I had them on backup, and we did this in an OR setting in the event that, they needed to have a thoracotomy. So another question. The question is, have you put cleaner through Cat 8 or Cat 12? I have not put it through Cat 8 or Cat 12. I don't think the device is long enough. I can't, you could maybe put it through Cat D, but the problem is that, Cat D is basically an 8 French, and that would be almost occlusive. So I don't know if it would be very helpful. Cat 12, I think, is too long for the device to go through. So again, I don't know. And again, it would probably be mostly occlusive in there too, so I don't think that's very helpful. And then what combos for DVT have you seen most effective? I think this case is a good example of where I think, we'll see what combinations work, I think, well. So, and again, to spare everybody the time and, again, dramatics here. I told the patient, again, young guy, I told him, there's two things that are going to happen. You're either going to take you're going to take the clot out and it's going to be fine, or you're going to wake up, with a, giant sternotomy. But again, the clot will be gone. So this was in the EP lab where they don't have DSA, unfortunately, but But this is where we snare the filter and it's trying to sheath over it. This is with the 26 dry seal. And you can see the clot starting to pooch out. So I always ask people when I show this lecture, like, what would you do here? What would you do? Would you stop? Would you go for it? Would you do something else? And it's always funny the answers I get, but most people say actually go for it. So that's what I did. And surprisingly, the filter came out, the clot didn't, but the clot didn't move. So that was a scenario that I wasn't really expecting was possible or that would happen. So, but at the time we were in the EP lab and didn't have much available to us. So, I tried doing a balloon here and, oh, Joe, thanks. Yeah. To your point, Joe, a cleaner will go through the Cat 8. Again, I don't know if that would be a very effective thing, but you guys have probably seen people do it. I don't know how much it works, or how well it works. But so we tried to angioplasty this, and nothing. It was surprisingly and we went up to I think a 20 or 20 Atlas, and that didn't really touch it at all. So what did I do? I put a filter back in. So again, this guy woke up. So I promised him the clot would be out, but I actually, I told him that we took the filter out, the clot didn't go anywhere. So we put the filter back in. So we're actually back at 1. So at this point, again, I talked to the CT surgeon. He said, I don't want to take this out. Or he said, I really would not, I think it would be a very morbid, surgery. So, whatever you can do, I would support, I'll back you up. So, at this point I said, okay, well, let's reschedule, let's do angiovac. Because if angiovac can't get this out, then I don't think anything can. So we went ahead, and again, this is just to show that the infrarenal IVC was pretty stenosis, and he wasn't having many symptoms in his left leg, and his right leg, was recanalized. So we didn't really feel that his IVC necessarily needed to be, completely stented. But we got access, again, this is now from the angiovac case. And I told him again before this procedure that, we'll do angiovac. If this doesn't work, then you're going to need to just go to the OR, or we'll have to figure something out. So I told him, this is my last ditch effort. And to be honest with you, I'm surprised that he still stayed with me, but I think he appreciated that I was very honest and upfront with him. So again, another dry seal sheath. We took that filter out. We knew that the clot wasn't going to go anywhere, so that made things a little bit less scary. And this is with the angiovac device in there. And this is post-angiovac. Nothing happened. And this is right around the time Inari, kind of came out with FlowTriever and ClotTriever. And so they were very eager to show me that, FlowTriever would work well for this, or potentially work well for this if, angiovac doesn't. And so this is probably an example of a $50,000 case that my management was really mad at me about. But, so angiovac failed. We tried the FlowTriever, and this is with the discs and after the aspiration as well. And again, it's still there. So literally through the kitchen sink at this was probably going to stop here, to be honest, just because I ran out of ideas. With that said, I had done angiovac before, and I knew that the only thing that really seems to help with angiovac is cleaner. And now I've really adopted my motto to use cleaner with angiovac for every case almost. But this was the last thing that we wanted to try. So we did that. This is, I would say maximum, 15 seconds of running the cleaner with the angiovac on. The cannula immediately got, occluded. So they told us to stop. And you can see that we did a run and the cavo was widely patent. And then we did a pulmonary angiogram to make sure that we didn't, send the clot up north. And by that time we had cleared out the circuit, and all that clot was in the angiovac. So just a nice example of, of where cleaner really plays a role, I think, in subacute chronic thrombus. And up until very recently, I think it's really the only device that worked well for chronic DVT. Or subacute DVT. And then the last case, I want to just show another for everybody that's still with us. This is a patient with acute portal vein thrombosis. Really nice picture here. And, I always ask people if they would go transhepatic. You can see there's ascites here. And then for us, what's really changed the game is being able to use ice and single stick puncture this. And again, you can see the kind of this beautiful venogram showing, outlining that clot. And so for this patient, you know, this is the distal, you know, that's actually, I think, the IMV. And you can just see how there's like a chronic occlusion of the SMV or a pretty subacute occlusion. So we lysed this patient from the distal SVC first, and we placed the tips in this patient. And this was, you know, after the first day, this is what we were left with, or this is what we had. So you can see the tips is patent, but the portal still looks really crappy. So at this point, now that we have an outflow, we've lysed this for a week, or sorry, a day. We brought the cleaner in, and again, really try to clean, you know, that out as much as possible. And this was what we were left with after that. So it did a really nice job of kind of clearing the channel again. Now that we had an outflow, I think it really helped. And so sorry I kind of rushed through that part, but, you know, in the interest of time, just wanted to conclude by saying, you know, dialysis access and maintenance is a common intervention in our practice. Attention to providing comprehensive care in the management of dialysis patients, along with providing quick and effective treatments, will be critical to keep pace with increasing competition and bundling of codes. And I really, again, I rushed through this part, but I think cleaner is a helpful device for thrombectomy and dialysis, along with other venous diseases. All right, questions? I think that's my youngest daughter who's sleeping in this picture, but I'm sure you probably heard her falling down in the background just a few minutes ago. All right, everybody. Well, I wanted to thank you all for, you know, taking the time out of your day to log into this talk and joining me to kind of go through these cases and this in this presentation. Oops, I forgot to mention the last slide here. This is
Thank you.
a small plug for Argon. If you guys aren't or into social media, you should definitely be following them on Twitter or LinkedIn. And I just want to then stop here, throw it back to you, Mary, and see if there's any additional questions.
Great. We didn't see that last slide, actually. So if you do want to follow us on Twitter, we are at Argon Medical. And on LinkedIn, it's Argon Medical Devices.